Good morning. We are here at the Oversight and Investigation Subcommittee hearing on combating the opioid abuse epidemic, professional and academic perspectives. Welcome. Less than a month ago, on March 26, we held the first in a series of hearings to examine the growing problems of prescription drugs and heroin abuse. During that brief span of time, according to the best estimates from the Department of Health and Human Services, at least 3,374 Americans will have died from drug overdoses, with opioids being the most common cause. That's 3,374 overdose deaths in less than 1 month. Indeed, during the time we spent in this hearing, another 10 lives will be lost. The headlines out of Pittsburgh last week sent shockwaves throughout my district with 10 heroin overdoses in a single 24-hour period. Of the two who died, they were found with stamp bags marked either chocolate or, quote, chicken waffle. And this is what we're up against. This is what is killing our sons and daughters, brothers and sisters, mothers and fathers. Let me state clearly so as to leave no room for doubt. Our current strategy just isn't working. And I'm not going to stop until we start moving in the direction of success defined not just as getting individuals off of street drugs and onto a government-approved opioid, but getting them to the point of drug-free living. About 3 weeks ago, on the very same day this committee held our first hearing on this issue, the Department of Health and Human Services released its long-awaited three-part plan to reverse this epidemic. Elements of the plan made sense. However, I'm puzzled and amazed to read one particular priority included in their press release, and I quote, "Exploring bipartisan policy changes to increase use of buprenorphine and developing the training to assist prescribing," unquote. We are in desperate need of innovations to reverse the current trend and not merely maintain it. Why would we focus only on a single opioid replacement program rather than the full range of FDA-approved treatments for opioid addiction? Why the fixation on one pharmaceutical product? According to testimony presented to this committee last year by the director of SAMHSA's Center for Substance Abuse Treatment, nearly 1 million people were prescribed buprenorphine in 2011. We know that number is much higher today, probably closer to 1.5 million people or more. Think about that. Success by federal government standards for addiction disorders is 1.5 million people prescribed synthetic opioids. Yet consider the sad fact that states have not seen their investment in prescription clinics reverse this opioid epidemic. States like Maryland, Vermont, Massachusetts, and others that have made massive investments in buprenorphine maintenance have not seen reductions in overdose deaths. On the contrary, things have gotten much worse. According to the DEA, buprenorphine is the third most confiscated drug in law enforcement activities in our country today, more than morphine, more than methadone, more than codeine. Patients are routinely getting buprenorphine prescribed as, quote, heroin helper, unquote, meaning they get a month's supply of buprenorphine to use whenever they can't get heroin. It tides them over, enabling them to remain in their active addiction. This should more accurately be called addiction maintenance, not just euphemistically called opioid maintenance. Some addicted to methamphetamines go to local bupe mills and get a 30-day supply that they promptly sell to buy their drug of choice. In the field of addiction treatment, the enabler is part of the problem. Helping intentionally or unintentionally to keep a family member as an alcohol or drug addict is enabling. Here, the U.S. government is the biggest enabler of them all. Some clinics operate cash-only businesses for writing 30-day supplies of buprenorphine at the highest permissible dosages, usually 32 milligrams, knowing full well patients will sell at least half of the pills in order to pay for their treatment or other illicit drugs. At our last hearing, Professor Sarah Melton at East Tennessee University noted that there are methadone clinics operating on a cash basis handing out methadone without any other treatment or buprenorphine pill mills. It is not acceptable that federal taxpayer money be used to support programs that hand out these drugs for cash. Worse, Professor Melton testified that there was a dearth of good treatment programs. And what happens after the patient leaves the treatment program? What is being done to follow up with patients to prevent relapses and put them on a path of real recovery? I fully recognize the importance of medication-assisted treatment as a transition from street drugs and to prevent overdose of heroin, but relying on this as the one and only solution shouldn't be the strategy. As I recently heard Dr. McClellan, the former deputy director of ONDCP, say, while there is an appropriate place for medication-assisted treatment, we should not turn a blind eye to the fact that there is also a tremendous amount of medication-assisted addiction. It is not acceptable for federal taxpayer money to be used to support treatment programs that lack evidence of effectiveness or that define success merely as an individual with an addiction disorder using heroin fewer times per week than before treatment. I'm calling for a patient-centered initiative with a goal of matching patients with the most appropriate care coupled with a focus on transition not just off street drugs, but eventual transition from opiates altogether. I hope to modernize our existing opioid addiction treatment system to ensure that the right patient gets the right treatment at the right time. It simply isn't true to present buprenorphine and methadone as opioid-free treatment. We do a tremendous disservice to those living with addiction disorders when we advance disingenuous double talk and not state outright that buprenorphine and methadone are highly potent opioids. We're not going to end this opioid epidemic by increasing the use of opiates. We need an exit strategy that enables Americans to become opioid-free altogether. We can do better than addiction maintenance. We can, and we must. I look forward to working with my colleagues in HHS as we explore new innovations for detoxification and treatment models to transition individuals off of all opioids and into evidence-based counseling with non-addictive, non-narcotic behavioral and medication treatments. We don't do enough to help those addiction disorders. I believe in recovery. I believe in lives being restored so that every individual may live to their full God-given potential and do so drug-free. I consider opiate maintenance as a bridge to cross over in addiction recovery, not a final destination. At this point, the government simply stopped building the bridge. We've not yet fully helped move those with addiction disorders beyond opiate maintenance, and I seek to lay out a vision for recovery that includes complete withdrawal from opiates as an option. Once we lay out those goals, we can then move forward with research and clinical efforts and boldly declare that we are no longer satisfied with the status quo of opioid maintenance only. To assist us today, this subcommittee will hear from some of the nation's foremost professional and academic experts in the field of opioid addiction. Among these questions we hope these experts will address are what can be done to incentivize individual compliance with prescribed treatment plans and reduce the risk of relapse, what should be the aim of treatments for opiate addiction, and should reduce the intake of illicit drugs by these individuals to more moderate levels. Or should the aim be to place patients on a path to detoxification and ultimately a full recovery, ending all illicit uses and removing the need for lifelong opiate maintenance recovery? To what extent is the increased prescribing of methadone for pain contributing to more overdose deaths? Are Medicaid and Medicare payments for the treatment of pain incentivizing doctors to prescribe the opiates like candy for the treatment of pain? Today, we have assembled some leading opioid addiction experts. We're here, welcome you to get your thoughts on dealing with this epidemic. I thank you for your expertise. Look forward to hearing your testimony. I now recognize Ms. DeGette for 5 minutes.
Thank you so much, Mr. Chairman. Before I make my opening statement, I want to announce today is Take Your Daughter to Work Day. My daughters tragically have grown up, but I have my daughter for the day today, Paula, who's with us. Paula is a student at 6th grader. Paula's a 6th grader at Howard Middle School, and she's going to be with me today. She just told me she thought it'd be really boring to come to the Capitol, but actually so far she's found it to be fascinating. So I think she's got a career ahead of her in politics, and we're glad to have her. I'm also glad, Mr. Chairman, that we're having this hearing today. This is our second hearing in the series on this very important issue. This is a problem that touches all parts of the country and is growing. In 2013, 50% of all drug overdoses in this country were related to prescription pharmaceuticals. In Colorado, my home state, the rate of prescription overdose deaths has quadrupled in the last 10 years. I'm happy to have this distinguished panel today who I hope can actually talk about, Mr. Chairman, what you suggest, which is science-based treatments and the best practices for treating this disease. All of our panelists have years of experience treating patients struggling with addiction, and I want to hear what all of you think is the most effective treatment. In our last hearings, we received considerable testimony from experts who told us that medication-assisted treatment, or MAT, can play a vital role in treating opioid addiction. Experts tell us that a combination of MAT and behavioral treatment, such as counseling and other supportive services, is the best way of treating opioid addiction. And of course, there are several FDA-approved medications that have proven effective in treating opioid addiction. Now, Mr. Chairman, in your opening, you talked about science-based treatments, and I completely support that. You also talked about patient-oriented treatments, and I support that too. But in doing that, we need to recognize that while it's the goal to get everybody off of these drugs if possible, it's not always the case, and we need to look and see at the treatments that should be available for every patient. And so in an ideal world, we would have all the options available to every patient, and we should strive for that. But right now, MAT is not an available option for all patients. Dr. Basaga, for example, would testify today that very few patients with opioid addiction receive treatments that have been proven the most effective, which includes access to MAT. What many Americans receive instead is a form of rapid detoxification from the drug, followed by an abstinence-only approach. Dr. Basaga and others have called this method outdated and mostly ineffective. And even worse, I suppose, it could be dangerous because patients face a significantly elevated risk of dying by overdose if they relapse. So I want to ask questions about that today. Is it true that most Americans with opioid addictions don't receive the most effective treatments? Do they and their loved ones understand that? Is it true that many patients receive treatments that some experts suggest may be ineffective or dangerous? And finally, why is not MAT available as an alternative to all patients seeking treatment? From the perspective of the federal government, it's important to have science-based policy so that we're expending our resources on efforts that actually have a chance of success. And patients seeking treatment for opioid addiction should be apprised of the benefits and risks of alternative treatment approaches. Now, I understand that we need more study to predict which treatment alternatives will be effective for any given patient. And that's why I look forward to hearing from Dr. Sapala about the work he's doing at the Hazelden Betty Ford to collect data on factors. And by the way, in that vein, I want to recognize our former colleague, Mary Bono, who's here with us today, and a former member of this wonderful committee. So we're glad to have you here, Mary. I also recognize that we need more study regarding how to best treat opioid-addicted patients for the long term, particularly people who want to taper off of the medications. And I certainly understand and support the desire to move toward medication-free recovery, but we also need to make sure that patients understand the risk. Finally, Mr. Chairman, much of what is being done to prevent and treat the opioid epidemic is happening on the state level. I'm hoping in one of our future hearings that we can have witnesses come from the states to talk about their approaches. In Colorado, for example, we have the Colorado Consortium for Prescription Drug Abuse Prevention, which is a statewide coalition and which is designing targeted programs. So when we have our hearing, I'd like to have someone from Colorado. I think that this hearing will give us more information and science-based decision-making is really what we need to make effective use of our resources to combating this very, very serious problem of opioid abuse. And I yield back. Thank you.
Thank you. I now recognize Vice Chairman of the full committee, Ms. Blackburn, for 5 minutes.
Thank you, Mr. Chairman. And it is indeed Take Your Daughter to Work Day. And after I get to Nashville this afternoon, my daughter will go to an event with me. But she is an adult and, of course, has 2 children of her own, and we will not take them to that event. It is so good to see our former colleague, Mary Bono, here, and I appreciate the good work that she continues to do on this issue. And Mr. Chairman, I thank you for the hearing because this is a critical public health issue and it does need our attention and our best efforts. And we're going to continue to look at this problem of prescription drug and heroin abuse because it has skyrocketed. And since '97, the number of Americans seeking treatment for addiction to painkillers has increased by 900%. That should give us all pause. Deaths related to heroin abuse increased 39% from 2012 to 13. That is a 2-year period of time. And while heroin use in the general population is still low, the number of people beginning to use it has steadily increased since 2007. And according to the National Institute on Drug Abuse, part of the explanation for the trend is a shift from the abuse of prescription pain relievers to heroin as a more potent, readily available, and cheaper alternative to prescription opioids. Addiction and deaths due to overdose are just the tip of the iceberg in terms of medical consequences of this problem. One tragic consequence of the problem is neonatal abstinence syndrome. According to Dr. Stephen Patrick at Vanderbilt, in 2013, Tennessee became the first state to make NAS a publicly reportable condition to the Department of Health. From information reported to our Tennessee Department of Health, we know the overall rate is 13 cases out of 1,000 births in the state of Tennessee. We can and we must do better for these babies. Our goal is to improve the federal government response to this crisis. Recently, we heard from witnesses who expressed the state and local perspectives on this issue. Last year, we heard from a federal panel of witnesses, including CDC, DEA, SAMHSA, NIH, and the Office of National Drug Control Policy. And today, we're rounding out this focus by hearing from you all, who will give us the professional and academic perspectives. And we look forward to your testimony today, and we welcome you, and I yield back.
And nobody else on this side seeking her final 2 minutes, then I'll turn towards Ms. Schakowsky for 5 minutes.
Thank you, Chairman Murphy and Ranking Member DeGette, for calling this very important hearing on prescription drug and heroin abuse in the United States. Also, thanks to our witnesses for coming here today to shed more light on this issue. This hearing could not be timelier. Increasingly, we're hearing reports of the toll this crisis is taking in communities across the country. And like myself, I'm sure that every member of the subcommittee has heard stories from their constituents about the toll of prescription drug abuse and heroin abuse, the toll that it's taken in their districts. I have mentioned previously before at this committee that I have a constituent, Peter Jackson, who tragically lost his 18-year-old daughter, Emily, after she consumed a single OxyContin tablet that she received from her cousin while visiting family. I look forward to hearing from our witnesses about the most effective ways to combat prescription drug abuse, to learn what additional steps we can take together to stop this crisis and to prevent the further tragic loss of life. I also want to call attention to the impact that reducing discretionary spending will have on access to treatment and research on addiction. Just yesterday, House Republicans approved budget allocations that will further cut discretionary spending for vital programs like SAMHSA and the National Institutes of Health. We've already seen devastating cuts to these same programs. For example, the Substance Abuse Prevention and Treatment block grant within SAMHSA, when adjusted for inflation, has actually been cut by 25% in the last 10 years. While we're here today to discuss the most effective methods of treating addiction, without federal funding for programs, patients will simply not have access to these services, and research on addiction and treatment of addiction will greatly suffer. That's just a fact. If we're serious about combating the opioid epidemic, it is incumbent that we provide strong federal funding for the programs that patients and researchers rely on. And I want to yield the balance of my time to Representative Tonko.
I thank the gentlewoman from Illinois for yielding. Each and every year, I have spent Super Bowl Sunday in a soup kitchen working alongside and serving individuals in the addiction recovery community. Why? Because I choose to land myself in the midst of real heroes. The individuals of the addiction recovery community, in my mind, through their courage, determination, and conviction, are truly heroes. Bearing witness to the joy and rebirth that recovery has brought to their lives leaves me no doubt that complete recovery to a substance-free life is and should be our goal for every person who is struggling in the throes of addiction, a disease. While recovery remains the goal, it is nearly impossible to achieve without access to effective treatments. Science tells us that the most effective treatment available for opioid addiction is a combination of medication-assisted treatments, commonly known as MATs, and behavioral therapy. MATs might not be the preferred treatment for everyone, but they constitute a vital tool in our toolbox for treating opiate addiction. Unfortunately, MATs were available in only 9% of all substance use facilities nationwide in 2013, according to SAMHSA. While I acknowledge the concerns that a reliance on MATs can raise, the immediate tragedy here isn't that some individuals won't be able to taper off maintenance medications. It's that most won't even be able to access an evidence-based treatment modality that has proven to be their best chance of easing the burdens of addiction and saving lives. Across my district, there are hundreds on wait lists to access this treatment. Every minute we delay needed treatment costs lives. In just the time that we are having this hearing today, 5 more people will die from an opioid overdose, and 4 out of 5 addicted to opioids will have no access whatsoever to treatment. This is totally unacceptable. No treatment option is perfect, and I strongly support further research that will help us create more effective treatments and cures that can rid us of addiction once and for all. For now, though, our focus has got to be on curbing the epidemic, expanding treatment, saving lives, and giving people the stability they truly need to achieve recovery. I look forward to hearing the perspective of our witnesses on these pressing issues, and I yield back, Mr. Chair, the balance of my time.
Thank you. The gentleman yields back, and so we will go right into our witnesses and try and get all your testimony done before we have votes, and we'll come back after votes, too. We have with us today Dr. Robert Dupont, the president of the Institute for Behavior and Health. Additionally, Dr. Dupont was the first director of the National Institute on Drug Abuse. Welcome. Dr. Marvin Sapala is the chief medical officer at Hazelton Betty Ford Foundation. As acknowledged, Ms. Bono is here with you today. Dr. Westrich is the president of the American Academy of Addiction Psychiatry. Dr. Anna Lemke is an assistant professor of psychiatry and behavioral science at Stanford University Medical Center. And Dr. Adam Basaga is an associate professor of clinical psychiatry in the Department of Psychiatry at the College of Physicians and Surgeons of Columbia University and a research scientist at the New York State Psychiatric Institute. And finally, Dr. Patrice Harris, elected member of the American Medical Association Board of Trustees. Dr. Harris has served on the board of the American Psychiatric Association and was an APA delegate to the AMA. I feel like I should be getting continuing education credits today for being here. I will now swear in the witnesses. You are aware that the committee is holding an investigative hearing and when doing so has the practice of taking testimony under oath. Do you have any objections to taking testimony under oath? All the witnesses say they do not object. So the chair then advises you that under the rules of the House and the rules of the committee, you are entitled to be advised by counsel. Do any of you desire to be advised by counsel during testimony today? All the witnesses decline. So in that case, would you all please rise, raise your right hand, I'll swear you in. Good. Do you swear the testimony you're about to give is the truth, the whole truth, and nothing but the truth? Thank you. All the witnesses have answered in the affirmative. So you are now under oath, as subject to the penalties set forth in Title 18, Section 1001 of the United States Code. We'll call upon you each to give a 5-minute statement. Just pull the microphone close to you, press the button to make sure the light's on, and try and keep your comments under 5 minutes. Dr. Dupont, you're recognized first. Make sure your microphone is on and as close to you as possible. Yeah, just pull it real close. No. Try again. Well,
there we go.
there you go. Thank you.
Thank you very much. Thank you,
Thank you.
Mr. Chairman. It's a privilege for me to be with you. And let me pick up on some of the things that were presented just now. I think one of the most counterproductive approaches to the problem is to pit drug-free against medication-assisted treatment. And I think every time we do that, we undermine dealing with the problem at all. We undermine public confidence, and I think it's contrary to what the public interest is in public health. And let me be very clear that I believe that full recovery is consistent with continuing to take medications for opiate dependence, buprenorphine, methadone, and naltrexone. The issue to recovery, to me, is not whether they're taking the medicine, it's are they using drugs? Are they using alcohol? Are they still involved in drug-dependent behavior? And that is not compatible with recovery. And I'm going to talk a little bit more about that issue about drug use in medication-assisted treatment, which I don't think is recovery. And I think but I think that concept is very important, just like these patients taking psychiatric medicines is fully compatible with recovery. So I think that to me is a way to bring this together. And I also point out what Dr. Marv Sapala is going to talk about, the Hazelton program, which brings together the medication and the drug-free programs as the way into the future. And the last point I want to make before I really get started is to think about the elephant in the room when we're talking about recovery, and that is the 12-step programs, AA and NA, are an enormous part of what we're talking about getting well. We did a study of the first national study of the physicians' health programs, and we've now followed up with that 5 years after the mandatory monitoring, and 97% of those physicians were still in recovery 5 years after mandatory. And we asked them what part of the program was most helpful to you. And they were in very high quality treatment and many other services. By far, the biggest percentage was participation in 12-step programs as what was most important to them. So I want to make sure in our hearing we understand the importance of that in terms of recovery. Now, my focus is on the users, and I want to make one point very clear. Opiate dependence is not like the common cold. It does not go away. It is a lifetime problem. A person who has opiate dependence is going to deal with that problem one way or another for his or her lifetime. If you don't understand that, then the concept of treatment is confusing because you think you're going to be fixed in treatment. People are not fixed in treatment with opiate dependence. Treatment can help them find their path to recovery, but treatment is not recovery. And it's really important that people are not fixed in any treatment, drug-free or medication treatment. It's a lifetime struggle, and that's a very important perspective on this. Now, my concern is that treatment, when it does not match up with the disease. The treatment is always short-term. Even medication-assisted treatment, which conceptually goes on for a lifetime, has very high dropout rates, very rapid patients drop out of the program from medication-assisted treatment. And the other thing is a high percentage of people in medication-assisted treatment continue to use opiates and other drugs while they're in the program. That is very important to notice that and pay attention to that. But even more important, in the thrust of my testimony, all of it, is accountability for treatment. What are the results during treatment? What percentage of the patients are continuing to use drugs? How much retention is there? What is the retention curve of the program? How long do they stay in treatment? And when they leave, are they any better off than they were when they came in? Those questions need to be asked and answered in a systematic way. The other thing I pick up on the chairman's statement about the standard, what we want is recovery. That means no use of alcohol and other drugs, including opiates, not just opiates, but all drugs. That's what recovery is. It requires that. And what I am proposing and encouraging the committee to do is to look long-term, because the nature of the disorder is long-term. And I use a 5-year recovery standard. Start with a person who enters treatment. Where is that person in 5 years? And you can look at any program, drug-free or maintenance or medication-assisted, and ask the question, how good is this program at getting person into a stable recovery? That's one standard for all treatments, and it gets you focused on the long term. And when we do that in this country, including in the federal government, the whole game changes, and we have a mechanism to improve treatment. Treatments can all compete at a level playing field to achieve that goal. So that's my testimony. Thank you very much.
Thank you very much. Dr. Sapala, you recognize for 5 minutes.
Chairman Murphy and Ranking Member DeGette, thank you very much for inviting me to participate in this important hearing and for your leadership in addressing the crisis of addiction to opioids in this country. My name is Marv Sapala. I'm the Chief Medical Officer of the Hazelden Betty Ford Foundation. I attended Mayo Medical School and have been practicing in the addiction field for 27 years. On a personal note, I've also been in long-term recovery from addiction since age 19. The Hazel and Betty Ford Foundation is the nation's largest nonprofit addiction treatment provider, and we've been around since 1949. We have 16 sites in 9 states. We offer prevention and recovery solutions nationwide for youth and adults. At our facilities, we've seen a pronounced increase in the number of patients with opioid use disorders, paralleling the grim stories you've probably been hearing about in your districts for some time now. At our residential youth facility, for example, opioid dependence rates increased from 15% of patients in 2011 to 42% in 2014. That's a dramatic rise, and this is an especially difficult addiction to treat. Individuals dependent on prescription pain medications and heroin often face unique challenges that can undermine their ability to stay in treatment and ultimately achieve long-term recovery. They're hypersensitive to pain and more vulnerable to stress. Their anxiety, depression, and intense craving for these drugs can continue for months, even years after getting free from opioid use. They experience a strong desire to feel normal again, to escape what seems like a permanent state of dysphoria, which puts them at high risk for relapse. They're also at higher risk of accidental overdose during relapse because they no longer have the tolerance to handle the same doses they were taking prior to treatment. In other words, with opioids, unlike other drugs, relapse often means death. In 2012, we launched a new protocol to treat opioid addiction, the Comprehensive Opioid Response with 12 Steps, or Core 12 as we call it. Our approach is grounded in the traditional 12-step facilitation model and based on abstinence, but it now also utilizes the safest life-saving medications to keep patients engaged in recovery long enough to achieve lasting sobriety. We don't see a conflict in utilizing medications and pursuing abstinence. Just as Bob described, even when medications are part of our protocol, abstinence is still the objective. In fact, one might call it a third way because it strikes a reasonable common sense balance between those who see medication assistance and abstinence as diametrically opposed. Our Core 12 program includes changes to traditional group therapy, additional patient education about opioids, and the option now of medication assistance. We utilize extended release naltrexone, Vivitrol, as well as buprenorphine naloxone or Suboxone to help engage patients long enough to complete treatment and to become established in solid 12-step recovery. The highest risk period for relapse is the first 12 to 18 months after treatment, so we prefer to have our patients involved in on-medication, in outpatient care throughout this extended period. And our goal is to discontinue medication as our patients become established in long-term recovery. While our clinicians recommend which medication is appropriate, the final decision is up to the patient, and about a third of our Core 12 patients elect to use no medication. Indeed, medication only addresses the biologic aspect of addiction. Our broader measures treat the psychological, social, and spiritual components to improve psychosocial functioning, enrich relationships, and foster a healthier lifestyle. And those are the keys to recovery that lasts. Our Core 12 program has resulted in more patients completing residential treatment and a reduction in overdose deaths after treatment. While the research study of Core 12 is ongoing and we do not have full results yet, we do know that Core 12 patients stay in treatment longer. Our atypical discharge rate, those who leave treatment early, for our general population is 13.5%, and for those with opioid dependence who don't enter this program, it's over 22%. However, in this program, it's only 7.5%. Based on our early positive results, we plan to continue paving the way for others to use both scientific and spiritual solutions to engage more people in treatment, save lives, and ultimately help more people get into long-term recovery. I'd also like to emphasize the need to educate our wider culture about the dangers of opioid overprescribing. The troubling trends began to emerge in the late 90s after the FDA approved OxyContin and allowed it to be promoted to primary care physicians for treatment of common aches and pains. Education campaigns, often funded by opioid manufacturers, minimized risks, especially the risk of addiction, and exaggerated benefits to using these opioids long-term for common problems. When prescribing on a short-term basis to treat moderate to severe acute pain, opioids can be helpful, but when these are highly addictive medications are taken around the clock for weeks, months, and years, they may actually produce more harm than healing. An increasing body of research suggests that for many chronic pain patients, opioids are neither safe nor effective. Over time, patients often develop tolerance, leading them to require higher and higher doses, which ultimately can lead to quality of life issues and functional decline. It should be noted that doctors didn't start overprescribing out of malicious intent, but rather out of a desire to relieve pain more compassionately. We have a culture that seeks opioid medication for pain relief and not just for physical pain, but also to numb psychic pain. Some of these patients have a significant risk for the development of addiction in a culture that promotes quick fixes, instant gratification, and escapism. Medical professionals need further education about the proper use of opioid medications and their risks. The general public also needs such education to improve recognition of risk and limitations of these powerful, dangerous medications. It's time now to address opioid overprescribing and overuse without stigmatizing pain. This crisis deserves the attention you're providing today and requires a substantial response. Thanks again for having me here, for your leadership. I look forward to answering your questions.
Thank you, Doctor. Now, Dr. Westrich, you're recognized for 5 minutes.
Mr. Chairman, members of the committee, thank you very much for inviting me to speak to you today about treatment for opioid addiction. Dr. Murphy, before I start, I'd like to say that as a psychiatrist specializing in addiction, I'm particularly appreciative of the clinical awareness you have imparted to the Helping Families in Crisis Act, which will focus resources on helping our patients. I am board certified in general psychiatry, addiction psychiatry, and forensic psychiatry, and I serve as president of the American Academy of Addiction Psychiatry, which is a professional organization for psychiatrists who specialize in the treatment of addiction and other mental illnesses. My primary professional focus is on the clinical treatment of addicted people. I trained at Bellevue, where I worked for many years and continue to teach, and I treat people addicted to opioids in my offices in Manhattan and in New Jersey, where I live. I know this committee understands very well the lethal nature of opioid addiction. You don't need us to tell you about that. My main goal in speaking with you today is to underline what you have already heard. Opioid-addicted people need access to a broad range of treatments for opioid addiction. This must include access to medication-assisted therapy and treatment for co-occurring psychiatric disorders. I have treated homeless, heroin-injecting senior citizens, college students who snort OxyContin, and practicing attorneys who must take an opioid pill every few hours in order to continue seeing their clients. The death and destruction I have seen due to opioid addiction is profoundly disturbing. But thankfully, with appropriate treatment, the more common return to health, the workplace, and family is what keeps most of us doing the clinical work which helps addicted people in their search for recovery. Part of that clinical work includes full treatment for what is ailing the addicted person. Research demonstrates that the opioid-using person often has a co-occurring mental illness, like major depression, bipolar disorder, or PTSD. Sometimes the opioid user is self-medicating uncomfortable mood states, or anxiety, or just has difficulty soothing him or herself. All of these circumstances can increase the risk for relapse and require sophisticated and individualized psychiatric evaluation and treatment. Research makes it clear that prescribing the appropriate, effective medication to help the patient with craving, along with talk therapy and treatment for a co-occurring psychiatric disorder, gives the addicted person the best possible chance for recovery. That sophisticated treatment system must include access to well-trained clinicians who can select between the available psychosocial treatments like relapse prevention therapy, cognitive behavioral therapy, medications like buprenorphine, methadone, and naltrexone, and mutual support groups like Narcotics Anonymous. For many, mutual support groups like AA or NA can be extremely helpful, but they are not treatment, nor do they claim to be. They are support groups which can be life-saving for some and not so much for others. As you have heard, the available research has not provided us with a silver bullet that works for all opioid addiction. Rather, the data tell us that some treatment works for some opioid addicts some of the time. Others may respond to a very different approach. That is one reason we clinicians must have all available arrows in our quivers. We must have the skills and training for a broad array of approaches to meet the treatment needs of each patient. Quite often, using a treatment team approach that includes psychologists, social workers, nurses, and counselors is critical to therapeutic success. The wide variety of personal choices addicted people make about treatment is yet another reason for supporting the full spectrum of treatment possibilities, from medication-assisted treatments with buprenorphine and methadone to opioid blockers like naltrexone to relapse prevention therapy. Some patients demand to be treated without medications, while others clearly want and need medication to control their craving, and may also require more specific psychiatric treatment for any co-occurring disorders. The use of buprenorphine and methadone, which are both opioids like heroin, can be controversial. When I talk to opioid-addicted people and their families, I sometimes, but not always, recommend tapering or maintenance with buprenorphine or methadone. The question is not whether the medication has side effects, all medications do, but whether the risk is worth the benefit. Patients and their families need to know that detoxification treatment and drug-free counseling are associated with a very high risk of relapse. As with other medical conditions, the relevant question about whether a medication is worth the risk is the following. Compared to what? Is taking buprenorphine or methadone better than dying from an overdose? Better than contracting HIV or hepatitis? Flunking out of school? Losing a marriage? Losing a job? One-size treatment one-size treatment does not fit all, and different patients may need different treatments. But the very good news in this situation is that people who are able to stop their use of illicit drugs, whether through psychotherapeutic interventions, medications, and/or help from NA, or most likely some combination of the above, can return to vibrant and productive lives. It is that return to physical and emotional health which I find so gratifying and empowers me to help my patients to keep trying. Before I stop, let me reiterate my main point and what I know you have heard from many others. Opioid-addicted people need access to a broad range of treatments for addiction. This must include medication-assisted treatment and treatment for co-occurring psychiatric disorders. Thank you very much for inviting me today.
Thank you very much. Dr. Lemke, you're recognized for 5 minutes.
Thank you for inviting me today to these hearings. The main point I'd like to make today is simple. We don't just have an opioid abuse epidemic or an opioid overdose epidemic. We have an opioid overprescribing epidemic. Doctors are a major pipeline of misused and diverted prescription opioids. And contrary to what is commonly believed, doctors who treat addiction are not the main source of the problem. The methadone that accounts for 40% of single drug opioid pain reliever deaths is almost entirely in the form of pills prescribed for the treatment of pain, rather than coming from methadone maintenance clinics that treat heroin-dependent patients. We thus need to think broadly about the problem of changing the behavior of all physicians and not just those who treat addicted patients. I was pleased to see the education of providers was identified as one of 3 priority areas in the report issued last month by the Department of Health and Human Services, which called prescribers, quote, the gatekeepers for preventing inappropriate access. But providing educational material on safe opioid prescribing, even if it's free and readily available, won't be enough. To change doctor prescribing behavior, we need first to acknowledge the enormous incentives to prescribe opioids and the disincentives to stop prescribing. Many doctors are afraid that a patient will sue them or complain about them if they don't prescribe opioids, even when the doctor knows the opioid is harming that patient. Also, no insurer questions me when I prescribe Vicodin for pain, but if I want to prescribe Suboxone to help an addicted patient stop taking Vicodin, I typically have to spend hours fighting an insurance company to get the prescription approved. Despite the Mental Health Parity and Addiction Equity Act that Congress passed by a huge bipartisan margin in 2008, many insurers still resist reimbursing for addiction treatment. The solution to this problem lies in giving doctors tangible incentives to prescribe more judiciously, such that neither pain nor addiction is undertreated. Today, I focus on 3 areas where I believe this Congress can make a positive difference. Number 1, require revision of health care quality measures. Number 2, incentivize use of prescription drug monitoring programs. And number 3, scrutinize accreditation organizations and regulatory agencies. First, require revision of healthcare quality measures. The Centers for Medicare and Medicaid Services and the Joint Commission exert enormous control over how doctors practice medicine today. Their quality measures set the standard of care. In the 1990s, they urged doctors to prioritize pain treatment, and that is what we did. Prescriptions for opioids skyrocketed, not always to the benefit of our patients. CMS and the Joint Commission need to link quality measures to treatment outcomes for patients with addiction. This will incentivize hospitals and clinics to create an infrastructure to screen for and treat opioid addiction. Quality measures should also limit excessive prescribing of multiple drugs to the same patient, especially of controlled medications. A younger person with no objective evidence of disease should not be on 10 different medications, yet I often see this. And the medications frequently include an assortment of stimulants, sedatives, and opioids. Also, far too many patients are on a prescription of benzodiazepines at the same time as opioids, which greatly increases their risk of overdose. Finally, CMS and Joint Commission quality measures should not be linked to patient satisfaction with opioid prescribing. Illness recovery, not patient satisfaction surveys, should be the arbiter of quality care. Doctors are not waiters, and opioids are not items on a menu. Second, incentivize use of prescription drug monitoring programs. Prescription drug monitoring programs allow doctors to see all the controlled medications prescribed to a patient beyond just the ones that they prescribe. When physicians make use of prescription drug monitoring programs, prescription drug misuse decreases. Monitoring programs don't merely limit access to opioids when they should not be prescribed. They allow for patients who really need them to get them. The question is how to get more doctors to use these databases. By some reports, only 35% of prescribers use these databases. Here are some ways to incentivize doctors to use prescription drug monitoring programs. Make it a billable medical service. Mandate education on use of PDMPs when physicians apply for DEA licensure. Amend privacy laws such as 42 CFR so that healthcare providers can freely communicate with each other around issues related to prescription drug misuse. Third, scrutinize accreditation organizations and regulatory agencies. The Joint Commission, the accreditation organization which sets standards for hospitals, was instrumental in socializing doctors to liberally prescribe opioids for pain. The Joint Commission's campaign on treating pain was funded in part by Purdue Pharma, whose main product is OxyContin. I do not think Congress should allow a major healthcare accreditation body like the Joint Commission to take money from the pharmaceutical industry. In 2012, the Food and Drug Administration wisely rescheduled hydrocodone products to Schedule II, but the very same week, the FDA approved the use of Zohydro, a longer-acting opioid with high abuse potential, similar to OxyContin. The FDA's own advisory panel recommended not to approve Zohydro, yet it was approved anyway. Why? Do we really need one more high-risk opioid medication on the market? It seems to me like trying to empty a bathtub with a thimble while filling it with a fire hose. Furthermore, the FDA should live up to its commitment to stop approving non-abuse deterrent formulations of opioids, which it did not do when it approved Zohydro. And doctors and patients need to understand that abuse deterrent formulations make it harder to crush and snort and inject an opioid, but they do not prevent ingesting opioids orally at high doses, becoming physiologically dependent on and addicted to them, and overdosing on them. To sum up, Congress can push back against the opioid epidemic by requiring revision of healthcare quality measures to reduce overprescribing, incentivizing use of prescription drug monitoring programs, and scrutinizing accreditation organizations and regulatory agencies. All three approaches will save lives and improve the practice of medicine at the same time. Thank you again for this opportunity to testify and for your leadership in addressing this public health epidemic.
Thank you, Doctor. Now, Dr. Basaga, you recognize for 5 minutes.
Thank you, Chairman Murphy, Ranking Member DeGette, and members of the committee, both for holding this hearing and for inviting me to speak to you today. My name is Aram Basaga. I'm a scientist working on developing new medication strategies to treat opioid dependence. I'm also educating physicians nationally with regards to safe and effective use of these medications. And I have been practicing addiction psychiatry for the past 20 years. I'd like to speak on the opioid epidemic from the perspective of medical management. And I want to point out how our current drug treatment system in the United States is outdated, that it does not reflect the scientific progress we have made in the past 50 years. Our current system is built on the model for treating patients with alcoholism, and it is not capable of responding to the unfolding opioid epidemic. Opioid addiction is manifested by the compulsive use of opioid painkillers or heroin. Patients have abnormal activity in several brain regions and experience powerful urges to use that they find very difficult to control. This abnormal brain activity can persist for months throughout the abstinence, driving high relapse rates. Medications can stabilize opioid receptors in the brain, reducing craving, eliminating withdrawal, and blunting the patient's ability to feel the effects of heroin. These medications work best in conjunction with psychosocial therapies to produce long-lasting abstinence. This approach has success rates similar to treatments we have for many other medical and psychiatric disorders. However, in stark contrast to treatment for most other disorders, very few patients with opioid addiction receive evidence-based treatment. The traditional approach of a brief detoxification followed by a therapy-only approaches has no evidence for treating effectively opioid addiction. In addition, this approach can be very dangerous. Patients that do not receive medications to block the effects of relapse face an elevated risk of dying when they relapse. Sadly, all of us have witnessed it on too many occasions. So we have 3 FDA-approved medications: methadone, buprenorphine, and naltrexone. Methadone activates opioid receptors in the brain and blocks the effects of heroin or painkillers. Methadone-treated patients use less heroin, have fewer medical complications, and have improved social and work functioning. In other words, they are able to lead a normal life. Methadone is the most effective medications we have. However, it is a potent medication and can cause sedation or even death. Therefore, dispensing of methadone is highly regulated. Buprenorphine works similarly to methadone, but only partially activates opioid receptors. It also protects patients from overdose risk. Because buprenorphine is safer than methadone, less monitoring is needed, and it can be prescribed by the doctors in their offices. Naltrexone, the last medication, is available as either a daily tablet or a monthly injection. Naltrexone works differently from methadone and buprenorphine. It completely blocks opioid receptors, and it is used after detoxification to prevent relapse. It has no abuse potential. There is no withdrawal when it is stopped. Treatment with medication works best as a maintenance intervention without a predefined length of treatment. There is no scientific evidence showing benefits to limiting the time someone is treated with medication. Opioid addiction is a chronic brain disease, and it responds best to chronic treatment. Methadone, buprenorphine, and naltrexone responds best to medication that are tailored to their individual needs. All of these medications are needed to adequately address the opioid epidemic. Every American should have access to these medications, and with the help of a physician, help make an informed decision about their path to recovery. Regulations should be put in place to make buprenorphine and naltrexone available at every treatment center working with patients addicted to opioids. More than 100 of individuals, many of them young adults, die of opioid overdoses every day. Medication-assisted treatment is the best way to reduce the number of deaths on a large scale. Addiction is a treatable disorder, and a joint effort of health professionals, community advocates, and policymakers is urgently needed to reverse this tragic trend. Thank you for the opportunity to testify.
Appreciate it. We're going to try and get Dr. Harris's testimony, and then we're going to vote and come back. So you recognize for 5 minutes.
Thank you. Good morning, Mr. Chairman and Ranking Member and esteemed members of the subcommittee. I am honored to testify today on behalf of the American Medical Association. My name is Dr. Patrice Harris. I'm Secretary of the AMA Board of Trustees. I'm also the Public Health Officer for Fulton County, which includes Atlanta, and I am a practicing psychiatrist with experience in addiction. We are indeed in the midst of an epidemic. Physicians are deeply disturbed about the rise in overdoses and fatalities from prescription opioids, as well as the rapid increase in deaths from heroin-related overdoses. The numbers are sobering and unacceptable. The AMA is working on a number of fronts with many other groups to develop recommendations and implement specific strategies to confront this public health crisis. Physicians are stepping up and taking responsibility to prevent and reduce abuse, misuse, overdose, and death from prescription opioids. We also need to make sure that our patients who experience pain receive the treatment they need with opioids, if clinically appropriate, and that patients who have an opioid use disorder have timely access to affordable, comprehensive treatment. These are complex problems, and there is no one solution. A multifaceted public health strategy is needed. There are key components to this strategy. First, physicians must continue to amplify our efforts to train and educate ourselves to ensure that we are making informed prescribing decisions, considering all available treatment options for our patients, and making appropriate referrals for our patients with substance use disorders. As part of the prescriber clinical support system for opioid therapies funded by SAMHSA and administered by the American Academy of Addiction Psychiatry, the AMA is developing new training materials on responsible opioid prescribing, including a focused educational module on opioid risk management for resident physicians. Patients in pain deserve compassionate care just like any other patient we treat. The dialogue must change to reduce the stigma that's associated with pain. We need to increase insurance coverage for evidence-based, alternative, multidisciplinary, non-drug pain management therapies. At the same time, we need to support access to opioid-based therapies when clinically appropriate. Opioid use disorder is a chronic disease that can be effectively treated, but it does require ongoing management. Physicians need more resources so that evidence-based treatment, such as medication-assisted treatment, in conjunction with counseling and other behavioral therapies and interventions, are more available and accessible to all of our patients. There are not enough programs, and many are not affordable. We strongly support lifting the cap and expanding the number of patients that office-based physicians can treat with buprenorphine and Suboxone, which are major tools in treating opioid use disorder. Naloxone has saved thousands of lives across the nation, and we strongly support increasing access to it. We encourage physicians to prescribe naloxone to their at-risk patients, but barriers still exist to using this effective drug to prevent overdose deaths. Now, one way to reduce one of these barriers is passage of Good Samaritan laws so that healthcare professionals, first responders, friends, family members, and bystanders who see someone who has overdosed can help save a life without fear of liability. Last, prescription drug monitoring programs can be a helpful clinical tool. However, to be most effective and used more often, PDMPs need to be real-time, interoperable, and available at the point of care as part of a physician's workflow. In order to get to this point, though, Congress needs to fully fund these programs so that states can modernize and fully fund and staff them. So in summary, we know that it is up to our profession to provide the leadership necessary to confront this epidemic. And we commend this committee's leadership and look forward to working with you and other stakeholders to promote evidence-based solutions. Our patients deserve no less. Thank you.
Thank you, Dr. Harrison. Thank you, the panel. We're in the middle of votes, so we're going to break here. It's going to take us about half an hour or so for votes. We'll come back. I just want to leave one sobering statistic I have here about this. In North America, the number of deaths from plane crashes between 1975 and today was 42,495. 1975 to today. For the United States, the number of drug overdose deaths last year was 43,000. It's if we were here having a hearing on plane crashes, we would need an arena to handle the media. What a sad day it is. With 43,000 people who died in this country last year, I feel that we need to have people understand the severity of that. I thank this panel for your testimony. We'll come back and ask you questions in a few minutes. Thank you.
Nice comment about doctors are not waiters. Who's menu items? I like that.
Thanks.
Sometimes I feel like
Right on time, 5 minutes.
I'd like to try some
Actually,
Prozac.
yeah,
You would?
right. Actually, the truth is doctors are waiters, but I can't actually say that.
Some ways. Well, you have to negotiate. But
Yeah.
Basically take whatever they want. They can get whatever medication they want. And so I have to negotiate that piece.
Yeah, right.
But sometimes I try not to be snarky, but I sometimes say, look, if I were managing the case, I would do this to the patient. But you are managing the case. No, I'm not, apparently. Because you're taking whatever you want.
Yes, like I don't have any control, yeah.
Right.
No, it's so true.
I think they get good messages from all the people.
Yeah,
That was
yeah, I hope it's helpful. I mean, I don't know, I have my doubts as to whether Chairman Murphy's good at anything.
He didn't seem like he was moving off his game, but he was paying attention.
Yeah.
He invited all of us here.
Right, yeah, yeah.
We're pretty much
I'm
on the
not-
same message.
Yeah, exactly. He didn't,
He could have.
he could have had a panel full of people who were like, yeah, no, it's true. It's
I
true.
love AA, but it's not a treatment for opioid addiction.
Yeah. Yeah.
I was saying,
I'm not sure he's persuadable, that guy. Yeah, well, you know, this is the second of a series of three hearings, and it's the first time.
We can do something on the floor.
He opened very similar message, and some, part of my message was geared towards, trying to convert him a little bit. Not that it's doing good, because he opened with the same message too.
This is great. Well, it was a pleasure meeting you. How are you? It's good to see you again. Scott from Congressman Murphy's office. How is everything? Good. Thanks for coming in, by the way. Oh, okay. I feel like we always run into you with whatever we're doing.
No one, all the addiction psychiatrists. My 14-year-old said in his health class, I'm going to write a paper about alcoholism because of my dad. He goes, I mean, that came out wrong. He's not an alcoholic, he's a doctor. His teacher looked like, what?
Yeah.
I think we're in a very good place. Some constructive conversations. Less support last time. That's what's
What did he vote in?
I don't actually know much about how government works.
I don't know why, why we're on the Committee on Energy and Commerce.
Yeah, so they have a lot of jurisdiction over things like the FDA. They have influence with the DEA, the Center for Medicare and Medicaid Services. They would have jurisdiction over, for example, making prescription drug monitoring programs across borders, things like
That's
that.
what we need, because where I am, I can check it for New York, and I can check it for New Jersey, Connecticut, and Delaware, but my patients are not idiots. I mean, they can just go next door, you know?
In fact, they're the opposite of idiots. They're like geniuses when it comes to that sort of thing, yeah. Yeah, so,
I imagine that would be hard
yes,
to do.
they're kind of like they're an investigations committee, so they're sort of like the watchdog. Energy and Competition sort of the watchdog folks. Or at least that's my impression of sort of where they end up having the most influence.
So is most of your work with addicted people or with pain?
Yeah, so I run the addiction medicine clinic at Stanford, but I do a lot with the co-occurring pain. I consult with our pain department, so I'm in that whole, my focus is really prescription drug misuse.